data he presented last night, I rejiggered my slides to be provocative. So rather than just talk about the therapy of adjuvant tyrosine kinase inhibition for early stage disease, I'll talk a little bit about, oops, there we go. His question was, should we genotype early stage lung cancer? And he left you with a question mark, but I think yes, absolutely we should, due to its value in prognostication, disease classification, and I think stratification if we're going to put folks on clinical trials. And the second question, will TKIs prove to be beneficial for resectable disease? I think the answer is clearly yes. I think there is a role for eliminating minimal residual disease even with therapies that don't eliminate all of the cancer. And then the aspect of continuous therapy, keeping people on therapy with high-risk disease. So we know that lung cancer is a dangerous disease. Even stage 1A disease, completely resected, has a 25% risk of death in 5 years. And then in the higher stage of resected, fully resected disease, you see a lot of events here on these Kaplan-Meier curves. So very dangerous, a lot of room for improvement. And when you think about resected lung cancer, the pie looks kind of different than when you think about stage 4 genotyping, okay? So this is every lung cancer that is removed by a surgeon. And here you see classifications including squamous as part of the pie, neuroendocrine cancers as part of the pie, and then all the genetic subtypes of adenocarcinoma, the oncogene-driven cancers that we know are very important. And I think what we've learned from stage 4 disease is that EGFR mutant lung cancer is a separate disease entity. It's a unique diagnosis. You got to make that if we want to cure people, we got to make the diagnosis, you can make the proper diagnosis and classify these folks properly. And so you can see how we're dividing up the disease using genetic testing in resected disease. And then we know that if you do genetic testing of resected disease, it has very important prognostic implications. So this is over 1,000 resected patients genotyped when I was at Memorial. And looking back retrospectively, the patients with resected non-small cell lung cancer and EGFR mutation were half as likely to die as patients with resected disease and wild type, not a negative for EGFR mutation. So that hazard ratio of 0.51 in a retrospective study, very powerful. The folks at Mass General before I got there were doing the same thing, and they looked specifically at the stage 1A subgroup, and look at this. The hazard ratio here for stage 1A, EGFR mutant versus not, 0.3, 70% reduction in the risk of death. Look at that Kaplan-Meier curve for survival. So knowing, don't you want to know if you have resected lung cancer, if you've got the EGFR mutation? I want to know. That's huge. And you know, how does EGFR measure up as a prognostic marker? It's right up there with stage in terms of point estimates for risk of death. You know, stage 1A to 1B is about the same. We worry about age, comorbidity, gender, cigarette smoking mattering in early stage risk. EGFR mutation is as powerful a prognostic marker as all of those things. Now, we know KRAS mutation is not prognostic. In the Memorial data, it didn't make a difference. In the LACE Bio data, it didn't make a difference. So yeah, maybe we don't want to check KRAS because it doesn't matter prognostically. But no, I still want to know if I've got a KRAS mutation because it's a unique disease entity. I want to make the diagnosis. And so we're going to have this situation where we're subtyping lung cancer, and we're going to have disease biologies varying between different disease types that as we classify them. And then we're going to have prognostic genes. And then you'll also have the benefit of having these classifications linked with therapies, and those then you'll have a predictive biomarker too. And then this is the point I want to make with ALK. You know, a genetic phenotype that is more aggressive but has a therapy linked to it is going to be pretty easy to show the benefit. So with ALK, I mean, I've been genotyping early stage disease for years. I've never seen an ALK positive resected lung cancer. If I did see one, I'd want to treat them with some drug therapy. So, so I think that there's value here in genotyping. Now, why test for a gene that's not prognostic, like KRAS? Well, you've just classified the adenocarcinoma, and that's important in classification to decide if a patient has multiple primaries, if this is a new cancer, a separate primary, or is it a stage 4 disease? And in fact, a work at Memorial, genotyping resected disease in people with multiple primaries showed that genetic profiling, and I won't get into this data for lack of time, was better at classifying multiple primaries versus metastases in, like 1 in 5, 1 in 7 patients. The genetics was better than Martini-Melamid criteria in distinguishing multiple primaries from mets. And so we all have patients in tumor board where we're trying to decide, should we resect this lesion? Should the patient have a second surgery? And what's the stage? So you see where I stand on genotyping early stage lung cancer. I think we should now, and I have a great job now. I work both at a cancer center and I also work in a clinic in a community center. So I know you obviously can't test everyone, but in my patients at the cancer center, I order the test. So now we're on to therapy, and we know that adjuvant therapy, quote unquote, cures people with early stage disease. This is the long-term follow-up of the BR10 cisplatin and vinorelbine study, and at a decade, the curves are separated. So you've cured some folks, a few folks, mind you, but you're doing some good there, and that's cisplatin and vinorelbine. And we also know that adjuvant therapy harms. So the long-term follow-up of the International Adjuvant Lung Trial shows that the curves come back together because there are more deaths in the long-term follow-up of the adjuvant arm. I mean, you give people 4 cycles of cisplatin, it slows them down a bit and maybe increases their risk of death from other causes. So the idea, obviously, to get this separation of the curves is we need better drugs that are less toxic, sort of obvious. Now, do EGFR TKIs cause harm? Absolutely they do. There's skin rash, there's diarrhea, there's the rare interstitial lung disease that can kill you. But what I hear again and again is that, oh, we can't give adjuvant EGFR TKI because you're going to create some monster clone that isn't going to respond when the patient. No, there's no evidence that earlier treatment changes the biology of the disease as if to make it more dangerous. I haven't seen this in these studies in advanced stage patients who get first-line TKI or first-line chemo. The trends are always favorable in terms of overall survival. In fact, certain recent meta-analysis show that first-line TKI actually improves overall survival in advanced disease. Now, on to this issue of if you're not curing with that quote-unquote magic, are you doing any good? You're stopping the cancer from growing. That's good, right? And you're less likely to die if you have less cancer growing in your body. And in fact, when you look at adjuvant imatinib in resected gastrointestinal stromal tumor, sure, it improves recurrence-free survival, but not overall survival. But when they compared a short 12-month versus a long 36-month duration of imatinib, here's that recurrence water, this Dr. Bunn pointed this out. When you stop the TKI, a lot of people recur. But keeping the cancer from growing actually might improve overall survival because the patient's living without cancer. That's a good thing. And in fact, you see an overall survival benefit of 0.45 in this study of longer duration imatinib. So why not give better drugs to the right patient? And in fact, this is the rehash of last night where Dr. Bunn showed the retrospective data from Memorial where patients who got perioperative TKI had a 50% reduction in their risk of recurrence or death, and the trend for overall survival was very favorable. And then this was corroborated in a prospective study, the RADIANT study in the EGFR mutant subgroup. Now, the EGFR mutant subgroup in RADIANT was only 150 patients because patients were enrolled in that study based on other biomarkers. So I think there's clearly, you're stopping the cancer from growing, and I think there's benefit to that in high-risk patients. Now we've got Alchemist up and running, very exciting, genotyping thousands and treating hundreds with larger sample sizes that might show that survival benefit in the long run. It's going to take years and years to do this, so I agree with Dr. Bunn that neoadjuvant approaches are the way to go. But at least we have the platforms. And then worldwide, we have a lot of effort And I'm excited to see comparisons, not to placebo, but comparisons head-to-head of chemo versus TKI in high-risk patients. And we're going to have this disease next year. We're going to have this data next year. So this stuff is coming. It's interesting. It should be done. The RTOG is doing a very interesting study where they're giving patients with the mutation a TKI as a run-in to concurrent chemoradiation. And I think certainly shrinking the cancer would make you'd able to get more energy in and perhaps eradicate it better with radiation. So a lot of very exciting work being done, and then in China and Japan. So at Mass General, with our collaborators at Memorial and Stanford, we have a study looking at duration of TKI therapy. So we're comparing short course versus long course afatinib in EGFR mutant resected disease. The primary endpoint is recurrence-free survival. Now, the statistics were such that we needed 46 patients in each arm to detect a 20% difference in event rates. So we figured that without afatinib, about 40% of folks would recur. If you stay on the afatinib, that's 10%. If you stop the afatinib, it improves things a little bit, but you see that the sample size is we're looking at a difference of 5 events versus 14 events between the arms. The enrollment to date is 34, and already 3 patients on the afatinib 2-year arm have dropped out because the afatinib has been too difficult to take for 2 years. So you see what we need is a drug that you can take for 2 years and give it to high-risk patients, and then we'll see. I think we'll see the benefit. So I'm interested in if there's osimertinib studies in being developed. So should we genotype folks? Yes. Will TKIs prove beneficial? Yes. And then this issue of benefits versus harms. I think Dr. Bunn makes policy. I don't. Dr. Bunn's worried about cost issues, I think, and I'm not. So, but I think cost is a harm that we need to think about. Thank you very much.
So my question is, should you do all these testing at the same time or sequentially with the common ones first?
So it's selected patients, and I use the platform available at my institution, which is a snapshot type test and then ALK-FISH. So we do a package looking at EGFR, ALK, KRAS, and about 60 other genes in my institution, and I'm hoping that economy of scale, as we get technology, we can do large platforms with larger genes. I don't care if I learn useless information. Bring it on. If it's cheap and you can do it, why not?
It's distressing to me that all of those adjuvant trials had relapse-free survival as their primary endpoint.
Yes.
This is curative intent therapy, and yet we do 2 years of treatment with a 2-year RFS endpoint. Of course it's going to be positive.
Positive, of course it is.
And that's not answering the real question. So when you treat patients, with these drugs, does it take 2 years to achieve maximum response? No, it takes like 4 weeks. So the argument that you have to give 2 years of therapy, I think, is simply just telling you that all you're doing is suppressing recurrence and that you can treat these patients afterwards. And I totally disregard the imatinib data. I cringe whenever anybody uses that. Do you really think in an era of targeted therapies that every target is equivalent? That EGFR is the same as target, imatinib and CML? It's not. So I think we need to ask the right questions. So overall survival, do a proper randomized trial. I think Alchemist is a reasonable way to do it. But just doing these little diddly trials that you know are going to be positive doesn't teach you anything.
Thank you. Thank you very much, Dr. Cobone. I gave this talk to be provocative. So thank you for the counterpoint.
And I think I asked you to go people so they jump up to the bike. So one question for you. You have the better survival in the EGFR mutant patients. That's also a group that generally has less smoking and is probably overall healthier. The reason I bring this up is a lot of the data in the adjuvant trials is half the patients who die within 5 years die of other causes than their lung cancer. if you take adjuvant breast, predominantly they all die of breast cancer if they die within the first 5 years. Do you think, again, part of that survival advantage in that group is because they're not dying of comorbidities? So again,
Yeah.
it's more tumor related, where then you're saying the surgery is doing what it is.
I mean, the key is that EGFR is independently prognostic in a multivariable analysis, but it does confound with smoking and gender and low-risk aspects to decrease your risk of death from other causes, absolutely.
Since we know that it seems that brain metastasis is a huge problem in this patient population, so do you recommend in your patients, are you scanning their brains once a year, or what's your thoughts about brain metastasis in these patients in the early stage setting? That tends to be an area where we're seeing an issue, and certainly maybe the AZD9291 drug might be able to overcome some of that.
Yeah, I think that maybe surveillance of the brain is beneficial, which is why that we see a difference in small cell PCI in patients who are scanned more versus scanned less. So I think that in very high-risk patients, you worry about the brain and have a lower threshold to order a brain MRI, but I don't schedule a brain MRI in surveillance. But I have a lower threshold to check one.
Just a comment on Alchemist. So Alchemist does have a survival endpoint, and it has accrued, I think, for the screening part, about 500 patients. But then getting them onto the treatment arms is a lot harder. So those numbers are much lower, but they're accruing also. And then I think the real question is 2 years too short? And is the dose maybe too high? And I'm not sure how one can work that out, in a curative intent setting where so much time is involved for follow-up.
So Jerry, you had mentioned about prevalence of ALK positivity in early stage lung cancer. So far in Alchemist, among the patients we've screened, which is several hundred, the prevalence in early stage disease is approximately 4%.
Wow,
So
that's
it
impressive.
is a number that lends itself to us meeting the goals of having the estimated sample size for the outcome.
Great. Thank you very much.
Great. So on to the next talk with Jamie Shaft, attending physician at the Memorial Sloan Kettering.